Hi, my name is Hayley Suchland, and my presentation is over the rehabilitation of scapular dyskinesis. Some basic principles of rehabilitation includes beginning treatment as soon as the injury is identified, treating the patient as a person, not the injury. When rehabbing, we want to focus on what the individual can do rather than what they can't. We want to increase range of motion and increase the weight as the patient progresses. Some methods used to restore balance and positioning of the scapula includes assistance with the patient, exercises that focus on range of motion and strength, re-educating the muscles, and returning the patient to their activity. Using assistance helps relocate the scapula back into its normal position, and also helps the patient recognize and relearn their normal range of motion. An example of this would be the joint mobilizations that we see that are performed in the clinic. Assistance also allows the patient to feel a decrease in pain. To begin our exercise plan for scapular dyskinesis, we want to start out with some simple increasing flexibility exercises. Some of these exercises include the pec stretch, the sleeper stretch, the genie stretch, and the upper trap stretch. Next, we want to use isometric exercises, which include scapular pinches, robbery pinches, low roll wall isometrics, shoulder external rotation isometrics, and scapular depressor isometrics. Next, we want to use isotonics, which include scapular pinches with a TheraBand, low row with a TheraBand, shoulder external and internal rotation in standing, dynamic hug, scapular punches, and cheerleader exercises. Next, we want to work on some moderate shoulder exercises, which include seated rows, high rows, or any rows at all. Then we want to work on the lat pulls down, scapular clocks, wall washes, and manual resisted scapular strengthening. Next, once the patient is ready, we want to go towards aggressive activity-specific exercises, which can include standing cable column punches, bear crawl and Swiss ball, seated pike lift, and standing snow angels. It depends on whatever activity the patient is trying to get back to. A rehabilitation plan for type 1 scapular dyskinesis needs to include exercises that strengthen the serratus anterior and the lower trapezius. Some exercises that strengthens the serratus anterior includes scapular raises, floor and wall angels, and wall slides. Some exercises that strengthen the lower trapezius include prone horizontal abduction with external rotation and prone lower trapezius ranges of motion. Next, we need to focus on strengthening and stretching the anterior deltoid and pectoralis major and minor. Some exercises include pulling the arms behind the back, isolating internal rotation, and using a doorway to vertically stretch the arm back. Those exercises will target the anterior deltoid. Now, some exercises for the pecs include doorway lunge stretches, foam roller arm circles, and floor roll-away stretches. By using these exercises, this will focus on strengthening and stretching the inferior scapular dyskinesis issue. A rehabilitation plan for type 3 scapular dyskinesis includes strengthening the lower trapezius and serratus anterior again, as I mentioned in the last slide, and stretching the levator scapulae, upper trapezius, and the pectoralis major and minor. One exercise that really stretches the levator scapula includes chin tucks with head lifts. And some exercises that stretches the upper trapezius includes dropping the ear to the shoulder, crocodile posing, and cat-cow posing. Most positions in yoga work the upper trapezius very well. A rehabilitation plan for type 2 scapular dyskinesis includes strengthening the rhomboids, lower trapezius, and serratus anterior. As you can see, the lower trapezius and serratus anterior are very important when rehabbing scapular dyskinesis, as they are strengthened in each program. Some exercises for the rhomboids include scapular wall slides, real delt flies, and prone lateral raises. In order to stretch the infraspinatus and supraspinatus, some exercises include the pendulum, crossover arm stretch, sleeper stretch, and passive external rotation and internal rotation. To retrain the muscles, we need to begin with slow and methodical exercises to refamiliarize the muscles with the certain movements that we are trying to create. This allows the body plenty of time to remember them. Proprioceptive exercises help with this tremendously, along with electrical stimulation. As the patient is returning to activity, the most important thing to remember is as the patient is going through the rehabilitation process, allow them to do the exercises that don't irritate the scapula, such as non-affected arm workouts and leg workouts. Also, depending on the activity, the rehabilitation program should match its needs. Before the patient can return, they need to have proper mechanics and no pain, and this should continue throughout their workouts and activities. My PCOT analyzed a 26-year-old male volleyball player who suffers from type 2 scapular dyskinesis. His rehab plan focused on the use of proprioceptive neuromuscular facilitation, which allowed him to regain his range of motion, increase his function, and decrease his tightness in just 6 weeks.